Well, we'll make a start, shall we? Alf, good morning. You're currently
Julie, hello.
mute. Good morning, and thank you very much for joining me, and thank you to everybody who's joined this webinar this morning. It's great to have you with us to listen and participate in this really important discussion that we're going to have. There will be question and answers, and we have some support in the background looking at those questions, and I can see the questions too. And so we'll crack on then. And again, thank you very much, Alf, for joining me. Alf is one of our newer trustees and joined us from NHS England. My background is as a nurse, as many of you may know, and I've worked in the NHS all of my life. So we're coming to this with a perspective of people working in the system, which has its advantages and disadvantages. But for the purposes of today, we're hoping that we'll be able to generate quite an interesting and important conversation about what we're doing. We don't pretend to represent all patients. I think it's important to say that but we do think that the concepts and the principles that we're talking about are applicable across the board. So we hope you'll find it interesting. So again, thanks, Alf, for joining us. Perhaps you'd just like to introduce yourself a little bit, and then just start by talking about the 5 phases of active participation in decision making for patients, because I think it'd be really helpful just to set the context.
Thanks, Julie. So yeah, morning everyone. I'm Alf Collins. I'm a doctor by training, recently retired. I was a community consultant in pain management for many years, and for 10 years worked for the Health Foundation on its person-centred care programmes until 2016, then moved into NHS England as the National Clinical Director for Personalised Care, with responsibility for, amongst other aspects of person-centred personalised care, shared decision-making. I think of shared decision-making actually as just good care, just good care. We tend to think of it in terms of a number of different phases. There's various descriptions of it, but I tend to think of it as having 5 phases. They kind of overlap. The first one is developing rapport and trust and a relationship. Of course, if you are a GP or work in primary care, and care continuity is an important element of the work that you do, then that relationship is often already formed. But of course, others who work in perhaps community services or secondary care, tertiary care services, developing a relationship is really important. Supporting people to tell their story. I think many patients complain that they don't feel heard. There's reasonable evidence that we tend to interrupt patients after just a few seconds, 11 seconds actually, in a study by my good friend Victor Montori and team. So supporting them to tell their story, clarifying that a decision needs to be made, and sharing the options. Number 3. Number 4, supporting people to talk about their goals and their preferences. And then number 5, working with them to come to a decision that's right for them, and then documenting that decision. So a number of phases, but they do overlap, and actually, it really should feel like just a gentle conversation.
It's really interesting, isn't it? Because you talk about primary care and developing a relationship with patients, which is possible over a period of years. Often in secondary care, it's more of a snapshot, and as lengths of stay get shorter and shorter, and your intervention with clinicians in the secondary care environment becomes constricted for whatever reason, the ability to establish a relationship is really hard. So you have to work much harder, because it feels much more like a production line, doesn't it?
Yeah, it can do, can't it, Julie? And this is where I think, I tend to think, and actually the change model that we developed in NHS England is in order for those conversations to be rich and trusting and compassionate, productive, lots and lots of things need to happen. But broadly speaking, we need to make sure that patients are prepared. We need to make sure that teams are trained, and we need to make sure that at both a local but also a regional and indeed a national level, the system is supportive of these conversations. And just to loop back into this idea of being trained, if you have only got 10 or 15 minutes in a secondary care clinic, the sense is that actually it's really, really important that we're trained in developing trust, developing relationship really quickly, and indeed having that rich, productive conversation. Because if we're not trained, if we haven't got a kind of a map in our heads as to how to conduct these conversations, they can kind of move all over the place.
And the thing we have to remember is that when somebody is sitting in front of you for whatever reason, they're probably at their most vulnerable and they're most stressed. And actually, if you're trying to have a conversation with somebody and they're not necessarily thinking straight, and they feel unable to articulate and express themselves, and if you know the patients, and just incidentally, I've just timed what I was talking, and only in that last few sentences, it was more than 11 seconds. That just gives an indication of how long 11 seconds is. It's a very short space of time. And again, if it's somebody that knows you, whether it's somebody you've been seeing a long time in the secondary care environment, or it's your GP or community nurse that you get to know, you can start the story somewhere further down the line. You don't have to start at the beginning. But if it's the first time you've met somebody and you have 11 seconds before somebody interrupts what you're saying, there's no way that they could have made any kind of assessment or understanding of what your issue is or who you are as a person in order to be able to have that sensible conversation.
Not at all. Not at all. Yeah. On the other hand, gently supporting people to tell their story, it might only take a couple of minutes, but that can feel like a great kind of outpouring. It can feel as though that person is genuinely interested in you as a person, actually. And certainly when I train people, and I do train people now, I do train people to really know that telling a story, as I've said, might only take 90 seconds or 2 minutes. We've got that amount of time, haven't we? Really?
Yeah, of course. And logically, if you get a better story and a better history from somebody, then it's going to put you in a better position to understand what the course of action is and what the options are and what's actually going on. Because often, I remember going to see my GP after I had my first daughter with a pain in my neck. And he examined my neck and said, "I really can't find anything wrong. Is there anything else going on for you?" And I just burst into tears. And clearly nothing wrong with my neck. And if I'd just gone in there and said, "I've got a pain in my neck," and not intending to be his pain in the neck, then I would have come out and I would have been no better off. And it was a completely different conversation then. So I think that's really important. Somebody's asking us for the source of that research on the 11 seconds, Alf. So I don't know, at some point you might be able to find that and we could let people have it. So I think that's really important, and it's not necessarily just the patients either, is it? It's about carers too. So patients don't have capacity, or just because they're vulnerable, they're not necessarily, they might be able to tell their story, but they won't necessarily be able to hear what's being said back to them.
Yeah, really important that people, if the context is right, having advocates with them, carers, relatives, friends, and actually thinking back, really doing a little bit of work, a little bit of thinking beforehand, preparing themselves to think about what they want to get from the conversation, to think about what really matters to them. And it's great that the Patients Association is doing work now on supporting patients to prepare for conversations.
I think so. Alf, a couple of people have asked us if we can just remind them what those 5 phases are. I think we kind of rattled through them a little bit.
Very quickly. Yeah. And this is my way of conceptualizing it. There are lots of different models. One's called the 3-talk model. There's another one called the 4-talk model. I think of it as phase 1, developing a relationship, but that phase kind of shifts across the whole of the conversation, actually. 2, supporting people to tell their story. Number 3, clarifying that a decision needs to be made and what the options are. 4, supporting people to talk about their goals and their preferences. And I can say a bit more about that if you like. And then 5, supporting people or working with them to come to a decision that's right for them, and then documenting it. So yeah, I mean, you could pull that out into 7, 8, or 9 phases. That gets a bit unwieldy.
Yeah. No, well, I think that's important. And somebody else here is asking us about. I mean, it happens in all kinds of acute care, but also in primary care now, which is relatively new. You have to go through a series of triages before you actually get to the person that you think you want to speak to. So how, that developing a relationship is really hard then, isn't it? Because by the time you have to go through so many stages in order to get to the person that actually is going to help you.
Yes, and you might end up sitting feeling fairly grumpy just when you move into the conversation with them, and quite rightly, yeah, completely. So there is something about us not just preparing ourselves as patients now, not just preparing ourselves in terms of what we want to get out of it, but kind of centering ourselves in so much as we can in order to have a really productive conversation. But just as you say, Julie, most of us when we see clinicians are really anxious, really anxious for all sorts of good reasons.
And often patients aren't asked what they're expecting, what they want from the outcome, because actually what the clinician who's sitting in front of the patient might think needs to be done, or what the options are, or what the problem is that they're dealing with. Actually asking the patients themselves. This is often an issue with complaints, when people complain and they get a standard letter about what that we're sorry about this and we're sorry about that. Actually they just want somebody to understand what they want.
Yeah.
And what they want may be very different from what you think they want. And so it's really important to take the time to understand that, isn't it?
No, absolutely. And, again, there are a number of models of shared decision making, and one of the other models starts with so-called negotiated agenda setting. So number one, starting with the patient's agenda. Tell me what you want to get out of our time together today. What's most important to you that we discuss and decide in the time we have together? So I think it's really important to have that little line in the conversations pretty close to the beginning.
And I think one of the fundamentals, again, there's another question in here about, patients being made to feel like they're an inconvenience, like everybody's really busy and in a hurry all the time. And sometimes it takes quite a lot for people to actually turn up in the first place to try and have the conversation. And if what they're met with is a sense that they're just taking up time unnecessarily, or they're not as important as somebody else, or, I've got a really busy day here and I've got so many other patients waiting to see me, can you just please hurry up? And whilst it might not be said in that way, the implication from the body language and what have you could certainly indicate that. And that's really difficult, isn't it, for patients then?
Really difficult. And again, part of the training that I provide, a core part of it is being present as a clinician, being 100% present in that conversation with every individual patient. I do want to flip it around, and for a clinician, they're often seeing sometimes 60, 70 patients a day. And there's quite a lot of research that says that many clinicians feel quite anxious at the beginning of consultations as well. So we need to, certainly when I do training, I always factor that in. It can be a tough job. It can be a tough job, but that does not mean that we shouldn't be doing this really well.
No, and of course we know that where patients are involved in discussions and decisions and reviewing options and what have you, the outcome is almost always better for the system, but it's always better for the patient.
Always.
So taking that extra little bit of time is actually investing in good time.
Of course.
And we've had another question in about better informed patients, and this is really important, because whilst we can encourage all of our clinical staff to be better at this, to do the training, and that goes right through the organisation. We can talk about that in a moment. But actually, giving patients the tools that they need to be able to have these conversations. And you and I have talked before about the various unintended mystery shopping exercises that I've been engaged in with my family over the last 2 or 3 years. And at every point where there's been an issue or a concern through the care that my various family members have received, the fact that I've got an extensive NHS background and understand how systems work, and now I've learned so much since being part of the Patients Association as well, and how I'm coming at it. I've been able to navigate myself through some of those situations. It's been incredibly difficult and stressful and emotional, trying to advocate for people who are unable to advocate for themselves. But with all that knowledge that I've got and my expertise from my professional background, it's enabled me to know the people to ask and the questions to ask them. 99.999% of the population just don't have that. And one of the reasons I get so passionate about this is because I want everybody to be able to do what I can do, but it shouldn't be necessary, should it?
No, it really shouldn't, should it, Julian? We've spoken about the fact that it's been, tough for you and your family, really, really tough, and actually in a public service that's run on 170, 180 billion pounds a year, surely. Some of these basics, and they are basics, aren't they? We absolutely should be getting these basics right. And the fact that you're so articulate, you're so able, you're so knowledgeable about the system, and it's still been tough for you and your family. That says a lot, actually, doesn't it? Really does.
I mean, sometimes I think I might make it more difficult because I challenge people. And I think it's really important also to say that actually there are some really lovely, kind, caring staff out there, and we met some of the best of the best in the various journeys that we've been through, often from unexpected places, and it wasn't necessarily a particular person or a particular clinician. We had some fabulous care from a healthcare assistant in one example, from a junior doctor in another, from a senior nurse in another. So it's not a clinician thing, and it's not a training thing. There is something about the compassion that people feel and their ability to deal with difficult situations. But it does make me think, there is training and support people can have, because it is possible. It isn't always impossible. Everybody's busy. We appreciate that. Everybody is challenged. But if some people are able to do it, then it must be possible for everybody to do it, even if not to the same exceptional level, which would make a difference.
Yeah.
We've got another really interesting question here, Alf, and I'll be interested in your perspective on this. Somebody's asking about whether there's an opportunity from AI. As we have less interaction, face-to-face interaction with professional people, do we think there's a role around AI? I mean, I have a personal view about that, but I'll be interested to hear what you think.
So my personal view has shifted over the last year. Okay. I think the first thing to say is that there's a lot of hype around AI. For those of you who are interested in the kind of last word on AI in healthcare, do look at Jess Morley, Morley, Jess Morley's address at the Nuffield Summit a few months ago. So there's a lot of hype, but there's also a lot of possibilities. I've been working with a team at UCL looking at what AI might be able to bring. And I've been really, really impressed that actually we've been able to replicate incredibly compassionate conversations online through the use of AI. And, it feels when you're going through, it feels to patients when you're going through these conversations with an avatar, that it is so compassionate. You actually feel as though you're relating with a human being. So look, it's early days, but my mind has shifted over the last few months thanks to that work I've been doing.
Oh, that's really interesting.
Yeah.
I mean, my immediate reaction is no, you need a human, but that's because I don't know very much about it. But it's good if it's being developed in a way, and I think there's so many branches of medicine where AI can be really supportive and instructive and helpful. I think it would be a shame to lose that real kind of personal one-to-one where you can sit down with a person and you can feel the warmth and the compassion and the interest. If hopefully we get to that point, because I think the kind of the soothing effect of having that relationship with somebody and being able to talk about, what the problem is, I think is really important.
So Julie, I'm still very much in that space. It's really about what possibilities AI might be able to bring, I think, to enhance those human relationships. Let's see.
No, absolutely. We've got a question that's kind of bringing us on to what we wanted to move on to, which is around the barriers. I mean, I know we've picked those up as we're going on, but somebody here's asking is, can you describe reasons good personalised care and the duty for shared decision making and the shared decision making? So if there's just some barriers and what good looks like and what the barriers are to that.
Yeah, there's a heap of barriers. The Patients Association has done some work on this. There's been some other work done by the Health Foundation. They kind of fall into groups. So the first one that I think is really important is, I do this already. So clinicians who believe they're already doing it and perhaps aren't is a reasonable barrier, reasonably big barrier. Patients don't want it is another barrier. Again, the Patients Association has done some work on this. There are measures about the degree to which patients do want to be involved in decisions, and broadly speaking, it's about 95% plus of patients who actually really do want to be involved. So I do it already. Patients don't want it. My trust doesn't support it. Actually, this is a big one. If your trust doesn't support it, if the regional system and the national system doesn't support it, then you're less likely to do it. I don't have the time. That comes up again and again. Again, there's reasonable evidence that if you're really well trained and shared decision making is seen as a process rather than a single one-off event, which it nearly always is a process, and this patient preparation thing happens reliably, then it really doesn't take any more time. So those are the big barriers. Those are the big barriers.
And actually, it can end up taking quite a lot more time, because in the situations that I've been involved in, where I've been challenging the system and trying to get the best for my parents and my daughter and various others, I've ended up, and it's been often with the senior staff in an organisation. I said we'd come back to that, because it's all very well having people at the front line and the clinicians who are actually in front of the patients doing this stuff really well, but actually if the people in more senior positions don't support it, but they're often the people that I find are blocking what I'm asking for or what I'm advocating for, and it becomes such a loop then that
Right.
having that engagement with them and the challenging and what have you takes them a huge amount of time. Whereas actually, if they just engaged with me and my family, but more particularly the patient, whoever that was in the first place, we wouldn't have had to go through that. So that false impression that not involving patients in the decision making and having those conversations with people, there's a false impression that saves them time. Of course, it doesn't. It creates huge amounts of extra work, which could have been avoided, and it's completely counterproductive.
Yeah. Yes, of course. And what comes to mind as you're saying that is that it's really basic skills that absolutely matter in the final analysis. Really listening with genuine compassion and curiosity, really listening, and deep empathy. They're not special skills. All of us can draw on the kind of skills that we deploy in everyday life with friends and family. In fact, training people in shared decision making is often a matter of helping them engage with the skills that they, broadly speaking, use in everyday life.
Yeah. We've had an interesting question in about advocacy for people with disabilities or vulnerable people that might not be able to advocate for themselves, and where does the responsibility for that lie? Because you can enable patients, can't we, to be able to speak up for themselves and make sure they're asking questions in the right way and that they're engaging in the conversation in the right way. We can train clinicians, but if that dynamic isn't balanced because somebody's vulnerable or unable for whatever reason, they don't have capacity, then where does the responsibility for that lie?
Yeah, it is really tough, and it starts to get into some of the legalities of shared decision making. Broadly speaking, we should all of us as clinicians have a deep understanding of the skills required, and the skills required to work with people with low levels of health literacy, and people, of course, we need to be culturally competent. That means a pretty wide, pretty broad skills base. What I would say is that when we're working with advocates, if we're talking about best management of a cold, then it's a reasonable conversation to have with an advocate. if we're talking about whether to have major neurosurgery or not, then I think we need to make sure, we need to probably look up some of the kind of ethical principles that we should be adhering to before we have these conversations, because it can be an ethical minefield.
Yeah, I mean, I trained and did a number of leader reviews, which are looking into the deaths of people with learning disabilities, and in every single case where decisions were made without good advocacy for people with learning disabilities, their outcomes were poorer. And we all know that people with learning disability, their life expectancy is significantly less than those for members of the public of the population that don't have a learning disability. And that's shocking, really, because they are being let down by a system which is not making decisions with them and for them in a way that they understand, and they're being effectively shortchanged as a result.
Yeah, totally, absolutely.
We've got another question here about GP referral influence, and do we think? I mean, this goes back the old days of patient choice, which you'll remember as well, Alf. And I'm not really quite sure what happened to patient choice, where you could go and see your GP and say, I want to go and see X, Y, and Z consultant, and you could choose where you went for any kind of referral. I don't think that happens anymore, particularly, and I'm just wondering. Somebody's asking here about how that. Whether that's still meant to happen, and whether the patient's preferences get taken into account in that instance.
Yeah, well, I mean, interestingly, choice came under my policy portfolio, so there's still a legal right to choice, and in fact, it should be the case that patients are given a choice of provider. The degree to which it's happening, I'm uncertain. I guess what I would say about that is that the choice really should be meaningful. Very often it's based on geography and accessibility. It should be much more meaningful than that. It should be based on, experiences and outcomes in those services. And we don't currently have that data to inform choice conversations. That's probably one of the reasons why choice conversations are less common than we'd like them to be, perhaps.
No, absolutely. Somebody else here has commented about AI and said AI and human contact can be worked, in to get together, but then it needs to be targeted in the right way. So I think that's probably what we were saying.
Yeah, I think that's right. One thing that does come to mind again, which thinking back about AI, thinking back about really listening and empathy, and it's just come to mind. I didn't say it at the time. Is the underpinning of this is in fact empathy and curiosity. And Jeremy Howick at the Stonygate Centre in Leicester demonstrated that medical students are drained of empathy as their training progresses. And actually, I remember being trained as a doctor, being told that we had to make dispassionate decisions and be objective, be clinical. So sort of one of the basic underpinnings of really good care, empathy, is actually systematically being drained from medical students. And they're doing some really good work on kind of redressing that balance now in Leicester. Oh,
that's interesting. I mean, there's a really conversation to be had about medical students and junior doctors, and that's not for here and not for now. But yes, if it's not instilled at the really early stages of any kind of clinical training for any professional group, and then supported and maintained once people are qualified and they're working, when it's really hard when you're thrown in the deep end, then you don't have that foundation to go back to, do you? You do have that foundation and understanding of the ideas and the principles in order to then move on. Somebody's asking us here about patient case studies of support given. I don't know whether do you know of any reference material where any of these things have been written up, or even where the principles applied in a real life setting might have made a difference?
Oh, that's interesting. I mean, they're nearly all written up in academic papers. There are thousands of academic papers written about this. I mean, the case that comes to mind for me, and there's lots of really good examples. The one that really comes to mind is Southampton General Hospital, actually, and it sees itself as a shared decision-making hospital. And I've been there a few times, and it's striking. The invitation letters for patients have got shared decision making at the top and ask 3 questions at the top, which is a prompt to support patients to become involved in these conversations. The ask 3 questions is on the lift doors as you move through the hospital. Lots and lots of people have been trained. It's a great case example. That there were many more Southampton General Hospitals.
Yes, or maybe we can think about putting some links to those in our website if we can, if we can access some of them, because I think people would be quite interested in that. There's another comment in here about it says the NHS Constitution states that treatment can be declined, and the GMC guidelines support that, and this needs to be promulgated as one of the options available. Do you think that's discussed with patients in any great way?
Yeah, it's an important point actually. Every shared decision-making conversation should involve as one of the options doing nothing. And it's really interesting that the whoever it was put the word declined in there. It should be a decision not to proceed. Refused. You sometimes see in notes patient refused, and actually patient decided not to. Actually, it's much better use of language. Yes, every shared decision-making conversation should include a conversation about doing nothing.
Yeah. We had a really difficult conversation with senior doctors, with my mum, when we were at the point of declining the next stage of treatment, when they wanted to move her across counties again into another hospital, having already done that once and sent her back. And we said, look, this is not going to make a material difference to mum's outcome. Now we don't want that to happen. And the doctor I was speaking to found that a much more difficult conversation than I did. Now, it wasn't because I was being completely unemotional about it. We'd been through a really difficult journey with mum. My siblings and I had really full and frank conversations about where we were. We knew what mum's wishes would be because it had all been documented. So as a family, we would join together. We knew what we wanted and we knew what mum wanted. But the clinician that we were talking to found that really hard. And in the end, we had the discussion and we made it clear. I would be interested to see what was written in the notes as a result of that.
Yeah, right. Yeah, gosh, Julie, what a story. And I think part of it is that, and again, there's some research on this. Clinicians are trained and they are driven to treat. Yeah, and sometimes not treating can be seen as a failure on their behalf.
Yeah, it almost felt like I needed to give him permission to accept my choice.
Yeah.
And mum was in no fit state. She didn't have capacity. She wasn't going to be able to make the choice for herself. But we knew what her choice would be. But it was interesting and it was a struggle. And there was a number of those sorts of conversations where it felt like the clinician that we were talking to was underprepared to have that conversation and uncomfortable, just generally uncomfortable. He clearly struggled with it, and I felt sorry for him deep in my emotional state about my mum and the awful things that we were having to decide. I felt real empathy for the doctor who was in a situation where he didn't feel comfortable in having that conversation.
Well, the irony there, eh? You felt empathy for the clinician.
Yeah. I mean, to be fair, I felt empathy for me too. So it was a fairly joint kind of outflowing of emotion, but it was clearly difficult for him.
Yeah.
So we've had another question here about the best way to educate patients to come to appointments. Maybe we could just talk about how we support patients to be able to come prepared.
So there's a heap of ways of doing this, and what's fantastic is we've just heard in the Patients Association is we've already got some work on the website, but we're going to be doing a lot more work about this. Simple stuff. Just think, actually, what is it I really want to get out of this conversation? What is it that I want to say? What is it I want to discuss? What do I want to get out of the short amount of time I've got as a kind of a basis? There are formal kind of ways of doing this. One's called BRAN. So general practices or wards or outpatient departments that have BRAN posters up, and that BRAN it's an acronym. BRAN is about benefits, risks, alternatives, and doing nothing. So the BRAN poster says you might want to know about the benefits, you might want to know about the risks, you might want to know about the alternatives, and you might want to know about doing nothing for your condition. There's a similar poster called Ask 3 Questions, which again is a way of prompting people to become engaged in the conversation. There are these things called decision aids or decision support tools, which if we work in specialist clinics, we can make sure that they're available in the waiting room, and all patients are sent them before they come along to the appointment. So there's an array of ways of doing this, and you'll be able in the next few months, when the Patients Association has done the work, you'll be able to see it laid out in a much more methodical way than I've just explained.
That's really helpful, thank you. We're being asked what our views are on the explosion of current health apps.
Personal view is we just don't have enough understanding of how to assess their effectiveness yet. Clearly, there are some that, in inverted commas, work. Clearly, there are many that don't work, and I would not know which is which at the moment. As a clinician who's been pretty involved in some of this stuff over the years, so yeah, we need an evidence-based catalogue that we can turn to, and I think the current catalogues that the NHS England holds are, well, I mean, they're not up to date because everything's evolving so quickly. It's very difficult to keep up to date.
Yeah. I mean, I can see how you end up in a bit of a spiral, don't you? So you might think, I need to Google everything, and I need to find out. I'm going to go on Health App, and I need to find out everything I know about myself, so that when I go in to see whoever the clinician is, I've already got a good idea of where I am and what's going on and what I might want, because they might not ask me. But then what you might be faced with is somebody who's a bit irritated about the fact that you've already come in, self-diagnosed, and decided what the treatment is, when actually we haven't gone through an assessment process yet. But you can see how the response that you get might encourage you to make sure you do that more in the future. So it's that kind of shared, not getting on that kind of treadmill in the first place.
Yeah, absolutely. My sense, there's some good people involved in the development of the NHS app, and if we can make sure that that's the kind of single source of truth over the next few years, that'll be a significant step.
Another really interesting one here, Alf, which we can move on to. It says, Alf and Julie, what do you think about the term shared decision making? I don't like it. It implies that the doctor has a stake in the decision that's being made, whereas actually it's all down to the patient. The patient should be given all of the information, all of the options, and they should reach and which allows them to reach an informed decision. So I think what this person is suggesting is that the doctor is a kind of a conduit for telling you everything that you need to know, making the assessments, and then it's down to you alone to make that decision. What would your thoughts be about that?
Yeah, I've had a number of debates with a lot of people about this over many years, and many people advocate for supported decision making, informed decision making. Where I've landed is I'm still going for shared decision making, and the reason I'm saying that is that a very significant proportion of our population really just want to be told about the options, told about the benefits, told about the harms, and they want to make the decision themselves. I'd be that person, there's no doubt about it. There's also a proportion of our population that don't have the confidence to do that, are very, very anxious. And my view is that is then the clinician's job to absolutely stand shoulder to shoulder with them and demonstrably work with them to make sure that the decision is the right one for them. So that's what I think the shared really stands for. This was really, really well described by a great friend of mine, David Haslam, Sir David Haslam. He used to be the chair of NICE. Before that, he was the chair of RCGP. He developed a cancer 7 or 8 years ago and wrote an article about the fact that he felt so overwhelmed and so anxious. He really, really wanted the clinician to make the decision for him. Interesting.
Yeah, no, it is. I think when you find yourself in that situation, your perspective on things changes, doesn't it? It depends what if you're, for example, if you're pregnant, you have a very different approach to what you might want your care to be to somebody who might be terminally ill with cancer. So I think it's kind of it might be a little bit dependent.
Yeah.
And somebody's sadly saying the experience with their dad's decision to decline treatment meant that he was bounced out of specialist care, and the care then became very dismissive. And we had a similar experience with my dad, where we took him out of hospital in the end because they were putting him into this 12-week wait to be assessed for whether he needed to go into care or not. So we took him out, and the hospital were really grumpy with us about that, to be fair. And in the end, they had to construct a way of discharging him in order to get him out quickly, which, because of the way that they did it, it then created, because of the care costs, a significant financial pressure for my mum. And so you do kind of, you move through from one really difficult situation again. So, you know, to the person that's making that comment, you have my deepest sympathy, because it's so hard working your way through this, and then you end up in a situation which is worse than the one that you were in before, and the only person that suffers as a result of that is the patients themselves, which is really sad.
Julie, I mean, these are dreadful stories, aren't they? And again, to my mind, a lot of it goes back to the language we use. Patients and or advocates decided not to proceed, not, refuse treatment. Really, honestly. Yeah, again, it reminds me of Professor of General Practice in Liverpool a few years ago did some work sitting in primary care, watching conversations, and the paper that they wrote, one of the kind of bottom lines was patient involvement and decision-making was confined to them objecting to courses of action proposed by their general practitioner. Really sad.
It's sad. Well, I mean, I think you and I could talk about this all day, Alf, and possibly, tomorrow as well. But I'm afraid we're coming to the end of our session now. There's a number of other questions here. It would have been interesting to get into about, do we think people are behaving in a different way because of the liability? Possibly, but I think, that's about having the open conversation. Differences, whether it makes a difference when you're on the telephone. Actually, this kind, caring, shared decision-making, advocacy from patients, it should be completely independent of what medium you're using. I think it's just as easy to do it on the phone. But like I say, I'm sorry we can't get to any more of the questions now. We'll try and have a look at all of those and see what we can do. But for the time being, thank you so much, Alf. That's been a really interesting conversation. Thank you everybody for joining us. It's been really good to have you with us, even though I can't see you and I don't know who you are. It's been great that you've joined us today, and we'll hope to see you again at one of our future webinars, which we have planned for the rest of the year, and particularly during Patient Partnership Week at the beginning of September. So do join us for one of those if you can. Again, they'll be advertised on our website. Other than that, thank you very much, everybody.
Thank you.